Okay, good morning. Let's go ahead and kick it off. It's 8 o'clock this morning. Hi, good morning. I'm Dr. Austin Nation. Welcome to 340L this morning, health assessment. It is a pleasure to be with you all today. We have an incredibly long day as we navigate the content together. I'm going to mute whoever is in my background here. Oh, there's a few of you. If you're not speaking, I'm going to go ahead and mute you just so I don't hear all the background feed. It's a pleasure to be with you all this morning. We will start out. It looks like I'm looking for a couple more folks should be joining us this morning, according to what I just saw last night as far as an updated roster. So if things work out, I'm seeing now 15 of you. I actually have 17 on my roster. So one of the things we need to do is to figure out, actually I have 18 in the roster, put you in groups because minus these, this first go round where we're going to be on Zoom, God willing, the rest of our time will be in the simulation lab on campus for both the midterm and the final. So you will be needing to do some partner work. So as I was looking through your introductions, and thank you for those that did those, looks like I'm still missing probably, it looks like 3 of you did not complete the introduction. So if you can take time to please do that for me this morning, that would be wonderful. It looks like you all are from all over the map. And so what I want to start with this morning that was not part of the introduction, just to get everyone talking and ideally get you on camera so I'm not talking to a bunch of black boxes, but I feel like there's actually some students out there in Zoom land. Otherwise, it's going to be a long day for me looking at black boxes all day. So it's nice to see your lovely faces and to feel like you're in this journey with me today. So thank you. Thank you for coming on screen. So I don't feel all alone out here in the world. This is such a different sort of way to teach, particularly this course, because this is a hands-on skills lab. So we'll navigate our way through the day. But I thought just to get everyone talking this morning is that what's not in the introductions is I read sort of your business of who you are and where you're working and all of that good stuff is I like to add a little bit of fun fact to our conversation. That gets us all talking and engaged and in conversation this morning. And I will start this morning because you've read my bio. Like I said, this is a course that I teach on a regular basis. I really kind of like this concentrated format where we just do 3 dates and we're done. They're long dates, but we're going to get through them and I'll lay out the roadmap for you as we go through our morning here. But my fun fact is there's 2 fun facts I'll offer you. One is I am an avid world traveler. The last place I went was a Scandinavian trip to Norway, Denmark, and Sweden. I'm trying to get to all the continents in the world. So on my bucket list, I'm looking at going to Australia and Thailand next, and Japan will probably be the next top 3. And of course, with COVID, things have been derailed. So there's been no international travel, but I still have a few more places and spaces that I'm looking to get to in my lifetime. My other fun fact is I am an avid cat lover. Stray cats to be specific. Just got through this morning out there feeding all the neighbors' cats that come to my door every morning and throughout the day. I've given them names. I don't know if that's their real names or not, but I've given them names and just love those little furry creatures. And so, yeah, they help with what I call my stress reduction. So if everybody wants to check in with a fun fact or 2, that would be great. That'll get us talking this morning and I can find out hear your voices and start putting names with faces. That would be wonderful. And we can just go in any order. I'm going to resume my recording session. Okay, so one of the first things I need to touch base with you all about is they ask us in light of any clinical, well, that's not what you're supposed to see, is to share with you, that didn't work out right, information on, let me try it again. There it is. Okay, to share with you information, we have to cover these CDC guidelines that make sure that you understand how to properly put on and take off a gown. This is what I have to sign off on for you all on your behalf. So just a review of this sequence. You may know this sequence already. But it's important, obviously, as you all are heading out into the world of COVID, which may or may not be still there by the time you get done and graduate and do what you got to do, but it's out there right now, and it's been with us the last couple of years. And unfortunately, many of the educational institutes, much like Cal State Fullerton, have pulled you all out of a lot of your clinical courses for safety reasons, because we don't want you to be exposed to this. However, when you graduate and you get a job, on wherever place you get a job, there's highly likely you're going to come in contact with COVID patients or some other patients that are going to require you to understand the importance of donning and doffing of your PPE. So the sequence for putting on a gown, and they do some great visuals here. Step one, when you're putting on your gown, fully cover torso from back to knees, arms and end of wrist, and wrap it around your back. That's what they're suggesting. Fasten at the back of the neck. And they give a visual on how to put your gown on. Your mask, or your respirator, they call it. Secure the ties or elastic bands at middle of head and neck. You can see the positions up above the ear here, down below the neck. People do all kinds of interesting variations on masking, as you are well aware. It's my public health pet peeve is when I see people having masks hanging down here or hanging down their chin. Just all kinds of interesting things people do with masks, other than covering their mouth and their nose. You want to fit the flexible band to the bridge of your nose. That's an important piece of that, and make sure you have a snug fit to face and below the chin, right? So it doesn't serve you if the mask is not properly fitted. If you are in some places, they will do, particularly now that they're recommending N95s, they will do something called a fit test to make sure that your mask, and I do this when I was house supervisor over at Anaheim Regional. They would have us doing this on the off shift because I would work nights sometimes. Right now I'm working as house supervisor up at USC Keck, is my clinical gig. But the importance of really having the right size mask for your face, not because one size does not fit all. And the importance of making sure that you get that good seal. That seal becomes critical, because anytime you are not sealed completely in this area, you expose yourself to inhaling these respiratory particulates that can be incredibly harmful to you. Can't tell you the number of nurses that are out right now with COVID from improperly donning, doffing their PPE, or being exposed to patients or colleagues that they didn't know had COVID. I mean, we're in a crazy workforce shortage. God, that's a tongue twister. Workforce shortage. Yeah, okay, that's a tongue twister. That's happening right now. So importance of really making sure that you have a secure mask, and then goggles or face shields to cover your face or eyes if that's part of what you're being provided with or asked to do, particularly if you're going in a room with someone who's a known COVID positive. And then gloves, you want them to extend to cover your wrist. And they usually go over the ends of the gown to make sure that there's no getting in of anything. Again, this is primarily, I'm talking about it in light of COVID, but this would be the same protection you'd want for any kind of, contact isolation, respiratory isolation. What other isolations are out there right now? Any that'll put you in contact with body fluid that may be contaminated with something. Those are the ones that are most common. Keep hands away from face. Limit surface areas touch. Change gloves when torn or heavily contaminated, and make sure you do good hand hygiene. Any questions on the first part, putting it on? Okay, second part, how to remove it, right? There is a sequence. You don't just grab it and take it off, right? So the importance to safely take off your PPE. And it says remove all PPE before exiting the patient room. That's in bold here, so we want to take note of that. Remove the respirator after leaving the patient room and closing the door, okay? But gloves, outside of, if the gloves are contaminated, it says if the hands get contaminated during your glove removal, immediately wash your hands with alcohol or alcohol-based sanitizer. And using your gloved hand, grasp the palm area of the other glove and peel off the first glove. right? And then slide that clean finger up under the wrist of the other glove to peel it off and kind of fold them into one before disposing of it. That's the proper way to dispose this. Face shields. If your hands get contaminated during the process, again, immediately wash them, remove the goggles or face shields from the back by lifting the headband or earpieces. If the item is reusable, place it in a designated receptacle. A lot of us were having to put our little stuff in brown paper bags to reuse it throughout our shift or however long. I mean, it got really crazy out there for a season. And then the gown, this is also interesting. Again, the sequence of this stuff. Unfasten the gown ties, taking care that the sleeves don't come in contact with your body when you're reaching for the ties. Pull the gown away from the neck and shoulders, right? And then turn the gown inside out. So, and then fold it into a bundle and discard it into a proper waste container. And then the last step of this should be taking off your mask, grasping it from the ties, then grasping the ties or elastics from the face respirator, then the ones at the top, and then remove without touching the front. And I know I'm guilty of this one. This one I don't do well because I reuse my mask, and I like, okay, do not touch. Front of mask respirator is contaminated. Do not touch. I am so guilty of that one. Every time I do it, I go, oh, I shouldn't be doing this. So I ding myself on it, but it's a bad habit to get into. But the safe way to do this, you know, is again, don't touch this thing. It's been contaminated. And then wash your hands with an alcohol-based hand sanitizer, or obviously with soap and water if that's available. And they give you an alternative way to take off your set, where you're taking off the gloves and the gown together as another option, right? Grasp the gown in the front and pull it away from the body so that the ties break without touching outside of the gown only with the gloved hands, and then remove it and roll it up, and then peel off the gloves at the same time. So everything's sort of coming off here together as you're bringing all this stuff down and off of your body and keeping it away from your body. And then placing the gown in a proper waste receptacle. Goggles look about the same, so does the mask, but this is another way, sort of an all-in-one way if you want to get your stuff off that way. So there is the second way. Are there any questions on doffing of your PPE? Okay, I want to get that one out of the way. Great, we're off and rolling. Okay, so going back over to our content today. I might as well just stay here since I'm here. I was looking at your course shell this morning and all the people here, and we are 18 students. Someone thought some students were missing. I don't know, you're not, are you seeing my screen? No, you're not seeing my screen. God, lose you again. Come on, Zoom. Okay, let me go back in. Bring it in again. Okay. So, all right, here you are. So now you're seeing it. So we are 18 students. So everybody is registered here in the course. I'm going to put that on student view so I can see what things will look the way you guys are seeing them. Let me just flip this. There it is. Okay. And so you should be seeing what I'm seeing in terms of who's in the course. Again, Dr. Bayhan is the coordinator for this course for all of the different shells. And you have your little buttons here on the side. I do want to make sure that you have, obviously you saw how to get here, our home page, and here are our 3 dates. You should have, I put these dates in multiple places so that you have these dates at your fingertips. So know that those are our dates. Now, this is probably a great place to pause again and get your feedback. So today, we're going to spend most of the day covering our content. I have 4 modules to cover. On the 5th is your midterm. Your midterm will be done. Let me just give you an overview. Your midterm on March 5th, you will come in and you will do each of you will get 10 minutes to perform your one of the 4 first random health competencies for me. You and your partner will each get 10 minutes. So that's a block of 20 minutes on this day. My question to you all, because then after that or before that, this is the choice I give you all as adults. We need to then give you lecture content to cover and go over the other 4 modules that you will need to get signed off for your final on April 30th. April 30th will only be a finals competency sign off. So we're slated to meet 8 to 5. That's our time. We do all day on Saturdays. For the 5th, let me do the 5th first. And you may want to think about this to happen for the 30th, but let's do 5th first. Would you prefer to have your individual sign-offs first and then do all the lecture as an entire group, or the other way around, where you are getting the lecture first and then doing your competency sign-offs second? So in the chat box, let me do it that way. That way I can get everybody's responses. In the chat box, give me your vote. Why am I? Oh, there it is. Let me start putting in. Do you want to do sign-offs first in the morning to get that off your plate? Or do you want to do your lecture first? Okay, thank you. They're coming in. I see, okay. Okay. Sign-offs. I see a couple lectures. Okay, I need a few more votes. Does it matter? Thank you. Sign-offs. Okay, do I have a majority yet? Keep going. Those of you who haven't given me a thought. Thank you. I want to make sure this is a democratic thing. Sign-offs. Let me start with 1, 2, 3. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay, so 14 of you want to get signed off first. Okay, perfect. Because that means you want to get your anxiety off the plate, which I get. That makes sense to me as well. But I like to give you choices because I don't like to dictate. Because some people say, oh, let's all come together. Okay, because we will do this on campus in the simulation lab. We should be back on campus if it all goes well by March. So let me make note of your vote. So you want sign off first. Okay. So with that, then what I will be doing after we get done today, or maybe at some point today, depending on how clever I am going to set up, because I think I calculated with you all, I will need at least 3 hours of sign-off time. Probably then we'll start at 8 o'clock. Then that'll probably run me till, what did I calculate? 10 minutes, ideally 6 students an hour, 3 hours plus transition time. So I'm going to say 4 hours, 8 to 11, I'll set it up for. I may run late, and then that means lecture will go from 12 to 4 or 12 to 5. Okay, everyone has made note of that in their planning. So then you and your partner will need to decide, once I open up the calendar for you to sign off, what time you want to sign, what time do you want to come in and take your competency between this 8 to 11 a.m. window? And it will be first come, first serve. So I will set that up, and I will give you all a thumbs up when it's done. So you can do that, because right now where they're putting it, which I don't use, they have it on discussion. Let me just show you where I saw it. And maybe some of the other instructors use it this way. Oh no, it's not here for this one. It's on the modules. So anyway, let me run down the modules. So I cover this in my orientation video, so I won't do a lot of it. I do want to say how important it is for you to understand your shadow health dates. Shadow health is worth 30% of your grade, is 3 points. And actually then for the focused exams, there are additional points, but there's 10 3-point modules. And your first due dates for these are the 1st. So you should have gone in, paid for, registered for shadow health and found my section. Let me pause there. That's another place to do a pause. Let me stop this and let me pause record. Okay, so one of my favorite documents is this health assessment interview sheet, which is listed here under the modules, and it gives you some incredible questions to start thinking about as you're interacting with Tina. When did you feel well, fitting well? You know, when did you first notice a change in your health? It gives you general questions to ask, specific to the systems to ask, right? Does she have any of these things, right? It gives you all of these things to think about within that area of focus. Then there's additional questions at the bottom. Past medical history. Have you had similar episodes? What diagnostic tests have you had? Right? Have you been in the hospital with this before? Have you had any operations, blood transfusions, right? More health history questions, tons of them for you to think about to ask Tina. These help increase your score to get you that 85% that I was talking about earlier, right? Social personal history, cage questions around drinking alcohol, right? Ideas, and here's some other ideas, concerns, and expectations, right? That you can mention to Tina in terms of how you use these as education, to be empathetic. There's a number of ways that you can use them. Please, I always tell you in my welcome message to download these documents and have them handy. That way, when you're in shadow health, for me, I'm old school. I like paper stuff handy so that while I'm in my program, I don't have to toggle back and forth between a couple of windows. So do avail yourselves of that tool. That's one. Any questions on that tool? That's your health history tool. There are other tools here that you can use as well. Questions for comprehensive health history. If you go to this tab, this one is the one that offers you some other things to think about when you're doing your health history, a comprehensive health history. Age, race, ethnicity, who's giving the history, relationship, right? Past medical history, what to say for medications, identifying any remedies, allergies, hospitalizations, injuries, habits and activities you can ask about, right? Drug and alcohol use against smoking, sleep pattern, exercise, recreational activities, psychosocial. You're gonna do some stuff around mental health, right? What's the household situation? Is your environment safe, Tina, right? You have to ask her these questions, right? These help, again, bump your score up. So there are tools, there's beautiful tools here that are already here for you to use. For example, skin, hair, nails. Skin, hair, nails is one of the first assessments we're gonna go over. Here's some great questions to be asking Tina about as you're making your assessment, right? Because Tina, if you can replicate it with Tina, then you can do that same kind of skill when you're with your lab partners and when we get together face to face. Eyes, nose, ears, nose, throat. We'll be doing a section. That's one of our other sections to cover today, right? There's questions for that. Respiratory, we'll cover that today as well. And then some of the other remaining sections that we will be covering during our time together. So again, another wonderful, wonderful resource for you to use in terms of helping you navigate the health assessment one, which is your first big money one, as I would call it, because that's where you start getting into the sort of the meat and potatoes of how to navigate this. There is an acronym called Caldera. This is your Caldera worksheet. There's 2 acronyms you should remember for this course. One is going to be Caldera. The other one is called Old Cart, OLDCART. Have you heard of this one before? I'll ask it as a question.
Yes.
What is Old Cart?
Huh?
What does that mean? Old Kurt.
It's O is onset,
Yes.
L is location,
Beautiful.
D is duration, C is characteristics, A is aggravating factor, R is relieving factor, T is treatment, and S is severity.
Beautiful. So if you memorize that acronym or Caldera, I give you some choices to think about because they're basically the same. Character, onset, location, duration, things that exacerbate it, radiate it, or relieve it, or preceded it, and what it's associated with. How does this work? How do these acronyms work for you? You find out, for example, let me do one that I know won't come up. I don't want to give any clues away. Let's do, I have pain in my great toe. Let's do that one. I'm not going to put my feet up on the camera. They wouldn't be a pretty sight. I haven't been pedicured in a while. But, and I tell you, I have pain in my great toe. You would begin to ask me questions like what, nurses? If you're thinking of these acronyms.
I can't find where that worksheet is on Canvas. It's under modules and then week 1.
No, stay with me. I'm gonna go back. Week 2, Caldera.
Oh, I see. Okay, thanks.
Yeah, remember I'm jumping down because we got to cover the first few weeks to get you started. Yeah. So I'm starting up here with week 1, intro shadow health. I'll come back to SOAP notes, health history. There's a tab for introductions. If you put your introductions there, we did some of that. Those are there. And then comprehensive health assessment, Caldera, and pain scales, right? So let's just peek at pain scales. You probably know these already. You learned these in probably in some of the courses. There's a number of pain scales that we offer you to look at here in this course. You all know this one. Oh, let me start. What's it doing? Okay. All right, here's your nonverbal one. If you're someone who can't speak and you say point to where your pain is, right? You've seen this one, the Wong-Baker faces one. Most of you know this one. Rate your scale on, rate your pain on a scale of 0 to 10, with 0 being no pain at all, and 10 being the worst possible pain ever. You can't just say on a scale of 0 to 10. You must give it a context. 0 is what, right? So you give that whole explanation the way I just said it, right? So on my toe pain, where is my pain on a scale of 0 to 10, with 0 being no pain at all? Because people don't know our scale, 0 to 10. What does that mean to a lay person? I don't know what that means. And 10 being the worst possible pain ever. Now you've given me a context for that, and I can tell you, well, it's not the worst possible pain ever. 5's out in the middle, so I'm probably hitting around a 2 or a 3, right? So that was, and then of course, where is the location of the pain? You can have them graph it. This scale uses internal and external, so I would be telling you it's down here on my toe. And then there's some other tools here, words to help you with description. Is it intense? Is it sharp pain, right? Does the pain feel hot or cold or dull or tender or itchy or shooting, electrical, tingling, cramping? These are great questions, great expansion of your vocabulary around your ability to just do, tell me about your pain on a scale of 0 to 10. No, we got to be much more thorough, much more in depth, much more comprehensive as you're heading out as baccalaureate prepared registered nurses, that you can communicate that depth and breadth to your either your colleagues that you're giving report, or to your provider colleagues as you're calling to, you know, perhaps ask for, you know, some kind of analgesic or something, that you have given a thorough pain assessment. And so avail yourselves of that wonderful tool there. So, and then the other one, I'll go ahead and take it while I'm here as well, is something called SOAP notes. Students sometimes struggle with SOAP notes because most of you have learned to do S-bar, right? You all know S-bar? What's S-bar?
Situation, background, assessment, and recommendation.
Beautiful, thank you. So do you know how that works with SOAP? What is SOAP? Any idea? And that's usually the response I get. So go ahead.
It's subjective, objective data, assessment, plan, implementation, and evaluation.
Evaluation. Sometimes they put a SOAP-E, SOAP-E, IE at the end. So a little different than SBAR, but it's a wonderful way to think about how you're going to document and articulate your assessment, because you're going to also have to be doing some writing of your assessments at midterm and final, so be prepared to make a good note. What were your subjective findings? What did I identify when I asked my client questions about their problem? I have toe pain. I'll go back to toe pain. So let's do our old cart, or let's do Caldera. Let's start there. So what would you ask me?
Can you describe the characteristics of the pain?
Describe the characteristics of the pain. Okay, great. What else could you ask me? And I would say, well, it feels kind of crampy, achy. It hurts when I move my toe mostly, or when I walk.
Is it a continuous pain or does it come and go?
Great question. Well, no, it's pretty much there all the time. It just gets worse when I'm moving it around. It gets, right? Okay, there we go. Now where do you go?
Is there anything that helps your pain?
Yeah, it does. When I soak it in hot water, or when I rub some pain cream on it, that seems to help a lot. And I wrap it up with a heating pad.
When does this pain start?
Good. Okay. God, it's been like this for about maybe 3 weeks or so. Seems to be getting worse.
Are you taking anything for pain?
I usually take a couple extra strength Tylenol.
Does
Now-
it help you?
Does it help? You're asking me if it relieves me. Yeah, it takes the edge off of it.
How often do you take the
No,
Tylenol?
yours? Oh, I thought it's yours.
Yeah.
I'm like, oh, she uses for her hair.
Uh-oh, I heard somebody, somebody,
Maybe that's Luis.
huh?
Gabby, it's your mic.
Gabby, is that Gabby's mic?
Sorry.
Okay, I'm hearing some other stuff going on. Thank you. Okay, I can't see you all. There you are. All right, so how often do I take it? I probably take it, my Tylenol, probably about 10 times a day. Oh,
How many tablets do you take?
I take 3.
Whoa.
Do you know the dosage, the milligrams?
It's 1,000 milligrams. They're 500 milligrams apiece. Now I've given you some different information. I hear you guys are going, what's the problem with
The
that?
maximum you can
That's
take.
too much.
Okay, too much, good. Okay, now let's problem solve it. Good. Too much, good. I like, what else?
Have you seen your doctor to tell you how much you're supposed to take?
No, I just take it as much as I think I need.
Oh,
Okay,
but
now-
that's not a good thing to do. You're supposed.
Well,
You're
no.
supposed,
Now you need some kind of patient education.
right.
Okay, let's back up. Hold on. Yes, we do. Okay, what are you thinking, Eukarya?
What am I thinking for education?
There's a few things wrong. I just threw you a wrench into your
Mhm.
assessment.
Well,
You have some medication questions on those handouts I just gave you. So let's rewind and take a pause and go back to those, because I want you to
Okay.
start thinking. There's some things you should be thinking through. What are you concerned about? Let me ask that question, nurses. What are you concerned about?
Damage.
liver.
Liver damage. Thank you,
Liver
Andre.
damage, exactly.
I would hope somebody would be concerned about my dang liver, right?
But you also said 1,000 and then 500 and then 10 times and then 3 times. So you already got some ammonia going to your head.
Oh, there. Okay, thank you. I might be having some problems with getting the story right, right?
Yeah.
Okay, so what should I be taking if I tell you that wacky story?
What should you be taking?
What should I be taking recommended dosage?
Oh,
Two
well,
tablets.
first it'd probably be an
More than-
NSAID more so
You
than
taking like 2 tablets?
No more than 4
tablets.
digits.
no more than
Yeah.
4, but
How often?
No more
Every
than
6 to 8
no.
hours?
For about 4 hours.
4 hours.
Dorothy's giving me a 4 up there. About every 4 hours or so.
Yeah.
So nurses, health assessment. This is beautiful. You're going right where I want you to go. I tell you, I'm taking that much Tylenol to not to take the edge off my pain. That's a problem.
Mhm.
Where should you go next?
Teaching
Teaching, yeah, about what? What do you want to teach me about?
about the side effect of the medication you're taking, that you're taking it too much.
Good. Okay, I'll take that.
Causes.
I'll give you points
Well-
for that. Yes, I'll give you points for that. Okay, I see something in chat I need to be looking at.
And then you should be assessing for any jaundice.
Okay, now you're gonna start doing some liver assessment. Good, okay. But they're yet a bigger issue I'm concerned.
What's actually causing the pain? Like what precedes it? The antecedent aspect of it? Like, why are you having this pain that does it happen every single day, or does it happen when you come back from work, when you wear steel toe shoes? Like, what's the nature of your work?
Okay, so now you're inquiring about what I may be wearing on my foot. Okay, I'll go there as well.
Or
Okay,
is it possibly gout? I don't know. Or, there's different, like in that sense, like what's actually causing the pain? Because
Yeah, is there any
you
underlying
would need to
conditions?
stop the Tylenol if you've already have liver damage. So you're going to have a different route of pain relief. You know,
okay, I like where you're going. I like all of this conversation so far. This is beautiful. Now, you need a little bit more information about a couple of things that I still haven't heard from any of you yet in this
Is
scenario.
it past medical history?
I'm not there yet, but what are you thinking? I'll go there. There's a couple other things you should be curious about.
I think we need to assess his feet.
God dang it, hallelujah. I would be sorry, somebody would ask, oh, God dang it, what does that thing look like? What does it look like? Because I've told you about it. What does that darn thing look like?
oh, I thought it was up on the table already.
Oh, it's already, no, because we haven't seen the toe. We haven't seen the toe. This is just health history. We're just taking information.
Oh, okay.
We're only
Okay.
talking right now. So let's see that toe. And then I plop my foot up there.
So there's a
And
nail-
then I take my sock off and it's all pussy and red and inflamed. And it's starting to turn colors. It's getting a little
Yes.
blackish stuff on it.
Already infected.
Yeah.
Now where you going?
Infection.
Infection or
diabetic or
I was hoping somebody would give me maybe a little diabetes. But what am I curious there then with? Where am I
Maybe
going?
peripheral neuropathy, and he can't feel when his feet get cut.
Okay, so maybe that, yes. So neuropathy, good. I like where you're going. Good. I like this. This is good. Keep going. Where else are
If
we
your
going?
diabetes is controlled, if they do have diabetes.
So what am I gonna do, Jenny, with that? How am I curious about
Blood
that?
sugar,
blood sugar.
Let's get a
blood
blood
sugar.
sugar, right? Or I might ask them what?
Does he take insulin?
Medical history.
any medication like metformin or
History,
something.
medication. Is there a family predisposition? Are you taking any medication? Oh yeah. I'm supposed to be taking my insulin shots every few times a day, but I only get to it because of my budget. I only can take it one time a day.
Mm.
All right, how does that
He's
sit with you,
non-compliant
nurses?
with his medications.
What'd you say, Jamie?
Non-compliant with his medications.
Right.
Huh.
So
What do you want to do?
educate him and let
Education.
him know that this could be caused from him not taking his insulin, causing necrosis in his feet from getting cuts, and the infection being out of control, and he can't feel it.
Okay.
And
else?
yeah, it might end up losing his foot.
That's the worst result, right? Yes.
Worst case
Okay,
scenario.
so let me go back to my chief complaint, because this is a great run through for your focused exams, which I'll come to, because this is a very good focus run through for you all to get you thinking. I came in complaining of toe pain. nurses. You haven't, you've done some assessment and you've done beautiful, but you didn't address my toe pain. I'm gonna take you back there. I'm telling you, I'm taking all these dang Tylenol to get the edge knocked off.
What's your level of pain from 0 to 10?
Oh, we're gonna do a pain scale. Oh, I gave you that. I gave you about a 3, 2 or 3, but I told you it's about constant. And that's with my Tylenol. Where might you want to go next?
Does it
Other
radiate
medications,
anywhere?
is there any other thing that you do to help you with the pain?
That relieves it, something that relieves it.
Okay, it relieves it. I told you I soak it. I soak it and I put my little pain cream on it.
I think we should check for his sensations and see if he can feel like poke or anything, because it might have gone into his bone.
Okay, there's where you go. But I'm gonna bring you downstream a little bit more. I'm still having pain, nurses, please.
So we
Does it
should
radiate?
try and get you.
Empathy?
Huh?
I'm
Empathy?
sorry about your
I'm
pain.
sorry.
Empathy.
I'm sorry that you're in pain.
You what is? What'd you say, Eukarya? And I heard
I
Rose,
said empathy.
you're empathizing. Okay, good.
Yeah.
Thank you. There we get a little. Somebody get a little empathy. Good. What did you say, Rosa?
I was just gonna say, try and get some medication for you to be relieved of pain.
Hallelujah. You're gonna be my little saving nurse right there. Yes, please. I am taking way too much pain medication. It's doing way damage. You've all mentioned that. So now we need to go back and something's wrong with the pain relief for this patient, right?
Working.
Tylenol's not working. It's way too much at the doses they're taking. We know it's having adverse effects on their body. Please get them off that and onto something else as you're giving me all the education and you're talking about all the other bits and pieces. Perhaps we need and then you saw it and you saw how bad it looks. We need to do what in terms of other medication? Where do you think we need to maybe go? I'll push you a little more this morning.
Talk to the doctor about it.
About
So
where do you think we're going as a nurse? What are you gonna say to your provider? You gonna suggest anything?
Other
Oh,
pain meds?
Pain meds, is that what you're saying? Like the actual med?
Yeah.
You'd probably have to do a lab value first to see how messed up the liver is, but probably a shot, like a cortisol or something like that.
I like the way you're going. There's a great option. Maybe a cortisone shot would help this person. Or what else?
Topical.
Medication for the nerves,
Oh, I heard 2 things. Huh?
nerve medication,
Like what? What do you think?
like a gabapentin type thing.
Oh, a gabapentin. Maybe some neuropathy stuff. Yeah. Okay, there you go. Now you're expecting and thinking like I want you to. There we go. What else? Medication.
What you actually use, the soaking, that could be the first thing while you're trying to figure out other things, because you did say that relieved the pain.
I told you to take the edge off a little.
Oh, okay. Edge.
Am I happy with that? Are you happy? with
No, but we can start it.
that? Okay. And you're telling me it's all bad for my liver. I should come off of it. Then what the heck am I going to take, nurses? You don't want me taking that because maybe my liver's a little bad. You get my liver enzymes and they don't look so great.
How about some Toradol?
Oh, maybe some Toradol, non-narcotic kind of thing, huh? Non-habit forming. Might be a little bit stronger, right? You get where I'm going? Right? So when patients are having unrelieved pain, right, then I need to be I need to investigate and make my thorough assessment of the problem. But as I'm putting together my list of recommendations or my plan, and SOAP, we call it plan. So let me go back to my SOAP with you because you did beautiful with that example. That's beautiful. I'm going to pause there for you a minute and say, let's go back and look at how that would fit into, well, I'll do the one you know first. So S-bar, let's go S-bar. What's the situation?
Patient has toe pain and he's taking Tylenol that's unrelieving his pain.
Okay. SB.
He has a history of diabetes.
Yes. Good. What else? What else is in the background?
Not taking his insulin.
Not taking his insulin. Great.
No.
What else? Background.
He's had the pain for a while.
Had pain for a while.
Bad diet.
Bad diet. We didn't get much diet information, right? But could be, yeah. What else? What about history? I'll give you, what about family history? Would they be curious?
Yes,
Why?
because it might be something that's been going on with the family, like the diabetes.
Diabetes typically does, it runs down in the family, right? I'll do one more thing with you. Physical assessment wise, what else with this patient would I be curious about with diabetes? What are some of the things with diabetes that are risk factors for diabetes with patients? Related to diet, I'll give you a clue.
Weight.
Weight.
Heart disease.
Wait.
I tell you, I'm 300 pounds.
Oh.
Oh, you go, you go again. Okay, I'm 300 pounds. Now what are you concerned about?
Diet.
That's where the
hypertension.
education comes in.
About diet and what else?
Yeah, the food.
Exercise.
Exercise? I don't do much exercise. I just sit around and watch TV most of the time. My toe hurts. I told you it hurts to walk.
Heart disease.
Heart disease, maybe another one I'm concerned about.
Hypertension.
Hypertension, maybe another one I'm concerned about. Weight,
High cholesterol.
high cholesterol. Here you go. Good. Get you going. Great. All right. So A, our assessment would be for SBAR.
The assessment we did on the toe, it's gangrenous, shows signs of infection.
Okay.
Possible osteomyelitis.
Osteo, I like where you're going. Great. And then our plan would be, our recommendations. Let me just stick SBAR first. Our recommendations would be what?
Get some lab work done.
Some lab work done. We know we're going to run some labs.
It is pain under
Stronger medication for the pain.
Medication. What else?
Culture the area.
Oh, good idea. Let's get a culture of that. Let's see what's percolating down there.
maybe debride all of the dead tissue.
Maybe we'll expect to get our little debridement setup ready. I'll throw in an x-ray. I'll help you out because I probably want to x-ray that toe and just see how bad it is, right?
Mhm.
Anything else?
Education.
And education. Thank you. I'll take that one too. So how does that flip into this SOAP thing? This is where I'm going to go, and then we'll take a little break again. SOAP says for subjective data, this is what the patient says. For the purposes of shadow health, it includes family history, right? And those kinds of things. I will look at subjective data that you collected, right? The whole idea under subjective is what information you collected, subjective.
Mhm.
Assessment, this is all you. What did you see, feel, hear, smell, just the facts and SOAP. Any pertinent labs that can relate to what you're investigating, right? Regardless of whether it supports or negates your diagnosis. That's your O. What was your assessment? So it's a little different than SBAR, right? So we're gonna start out with everything the patient said. Then we're gonna do our assessment. And then A, in this one, they're saying it's diagnosis, right? Or assessment. It stands for assessment, but it means diagnosis, right? It's worded on the NANDA, right? For instance, there's a painful condition. I expect a diagnosis of what's causing the pain, and if analgesia is effective. If not, if pain-causing problem has an element of infection, actual potential causes, right? And then what's the plan? Similar to recommendations of SBAR. Here's it says, here's where you get to have fun. Brainstorm and include everything and anything that you can think of, right? You don't have to pull it out of books, right? What do you know? What do you know? Are there any refer to specialists or other disciplines? Remember that teach, educate, that you guys got that one beautifully. Feel free to make suggestions about meds, labs, anything else here, right? Etc. Okay. That's my intro to SOAP. And then they give you here, let me come, oh, there it is, it's opening up. Oh, it was opening up. Is it gonna open for me? May have to do a Let me see if I need to stop that share and do another one. Let's see what's happening with my document. What happened to it? Oh, there. Oh, it's just very slow to open. Okay, I see it now. They give you in here a wonderful, is this it? Where is it at? Okay, that looks like it here. Is this the SOAP note? Yes. And here's what a SOAP note actually looks like. So, you know, here's a rheumatoid right in both hands and feet, reports assigned 7 years ago, surgery, states the history of a knee replacement, reports taking multiple medications, subjective data. All the medications, states the lesion on the right forearm, is from scraping, reports right first toe. Great. Okay, then your objective data. Here we go. Skin tugger, warm and dry, normal, no tenting. This detail, capillaries less than 3 seconds. Nails are convex shape. The lesions on the right forearm. Here's some information about what it looks like. There's also a scar. So my assessment is risk for swelling, risk for impaired liver function, continuous use of medication, or in my case, over-medicated, and existing possible risk for liver damage I'd probably be putting. And then my plan would be the things I plan to do: educate the patient, encourage patient to participate, right? And these kinds of things. So that introduces you to SOAP. Okay, there's a kind of difference between SOAP versus SBAR. Any questions? Okay. So far I've done a nice help for you on your health history. I've helped and talked with you about documentation. We ran through an example of a scenario to help spark your thinking. You guys all participated. That was a beautiful little exercise, a great little simulation. So I'm going to go back. Let me go back to our modules because I'm still covering Canvas right now. So let me bring you back on share screen and let's continue our journey. So finishing up on Canvas, other things I want to point out to you. I think I gave you most of what you need for week 1, week 2. A lot of stuff here from mental health stuff you can read on your own. Skin, hair, and nails was going to be our jump off place today. I'm going to come back to this, but there is the 4 competencies that I mentioned for your midterm that you will need to be competent in, and you'll get one of these 4. I pull at random. First one will be skin, hair, nails. Second one will be ears, nose, and throat. Let me get there. Eyes, ears, nose, and throat. So it's a combination of these 2. And then also in this first go round is face, head, and neck. I forgot to do that one. And lymph nodes. And then we'll end up with respiratory in the first half of the course. You'll see here, there's some additional resources for you. There's also under share stream video link. Dr. Bayhan has put, let me show you if they're populating. Yes, bada bing. There's some videos here of some stuff if you want to look over any of this stuff, if this looks helpful or might be helpful to you. If it is helpful to you, avail yourselves of the resources that are on share stream course media. That's what that's all about. Once we finish respiratory, we go into cardio. Second half will be cardiovascular, which should have been moved down. Actually, I can't move these now. I don't know, they're in a lot of order for me. But the midterm competency, and this is the one I was telling you that they have set up here, time to demonstrate your competency sign off. For 10 minutes, you'll perform one of the 4 assessments that will be randomly drawn. You get a few seconds to review the rubric and then begin your assessment in real time. You need 75% on your competency with me to pass. You must come in rehearsed and practice. I start the clock, you're off and running, 10 minutes, pass or fail. So please, please, please practice, practice, practice. That is my mantra for 340L. Practice, practice, practice. So I'll create a calendar. Let me make a note here, create midterm calendar. So you can get yourself scheduled, midterm setup. So like I said, you can decide if you want to go early or late. You and your partner need to ideally pick the same time. So you and your partner need to decide if you all want to go early or late. And then you need to make sure that you're getting 2 times back to back. So that becomes a bit tricky there. We go into vascular. We talk a little bit about vascular section. You have your spring break, reproductive, GI, musculoskeletal. We do neuro. And then for the final competency, it's going to be one of these 4. Abdomen, cardiovascular, musculoskeletal, neuro. These tend to be a little bit more involved, more in-depth assessments. So any questions on your assessments, tools, or Canvas? Okay. And the last thing I cover here is your syllabus for this course. Go to the syllabus tab. You should have all been into it already. There's my office hours. I like to say a little bit about office hours. I set myself up to go with you all after this class, office hours, or you can just get me anytime by appointment. Please, 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 please text me. Text me is preferred method. Text is preferred method of communication. Please don't go to my email inbox unless you just want to sit there until I get to you. My philosophy is if you have a question that you need answered, you probably want an answer to it in real time. So the best way, the fastest way to get that to me is to shoot me a text. Then I know you're having a question about something and I can get back to you. If we need to ever meet, we will come back. This is our home base. This is our Zoom space. I can always meet you here, or I can also do a phone call. Some stuff I can navigate via phone call, some stuff I may want to show you. But shoot me, it always starts with a good text message. This class is taught 60%. I don't know if that's actually 60% asynchronous, synchronous, hybrid, because of how it's set up. So that means in between these 3 dates, you are tasked with practicing and preparing for it. All of it does not happen online. The majority of it happens offline, your ability to go practice these skills. President's directive around COVID, I need to say a little bit about that. If you should come down with COVID symptoms, please take care of yourself. This darn Omicron is going around. It's highly transmissible. We don't want anybody getting sick. So there is a website link here in your syllabus. It's on the homepage of fullerton.edu that you can get information about what to do with your COVID, how to report it. You don't want to come to school in class when we're together because we don't want to put anybody else at risk for COVID when we come together. So we're here to learn about health promotion, screening, and client-focused education across the lifespan. Here are our objectives. Learning normal versus abnormal physical findings. Demonstrate correct use of instruments, right? Head-to-toe assessments. Practice open communication between nurse, patient, and other providers. And those are what we are going to accomplish in our time together. DCE is our required, digital clinical experience through Shadow Health is required. And then also your textbook, we switched to the 22 edition is what we're suggesting you get, but I'm also told that the previous version will also work to get you through. Moving down, students with disabilities. If you have a disability and you need any kind of special accommodations, please notify Office of DSS. They'll get in touch with me and send me whatever I need to know about making accommodations for you. I am here to make sure you have what you need to learn and be successful. I told you about office hours. Be civil with one another. And you need a computer that works for Shadow Health to navigate this software. There is the PIN information. We went through that already. Content outline, I've gone through all the assessments of the areas we're going to be doing. And then it gets into your points here to tell you kind of how the items and the points of what we're doing. So you have your Shadow Health modules, you have a couple of focused assessments, You have your comprehensive assessment at the very end. This is your final comp. You have your midterm competency sign off with me and your final competency sign off with me, right? And so here's how it works. Shadow health, I told you, you have 10 of those. They're worth 3 points each. There's 30 points of your grade. And the minimum passing DCE score is 85% to get any kind of credit on any of those. Anything less than that will get you a 0. These are cut and dry. There is 0 or 3, 0 or 3. There's no in between. So please make sure to get these in before the deadline. Otherwise, you will receive a 0, okay? Your focused exams, you do 2 of those. They're worth 5 points each, right? So there's another letter grade, right? These will be on a pediatric cough or a geriatric person with chest pain. So these are very focused exams, similar to what I just did with you with the toe thing. It'll be a very focused exam for you to navigate on these two ones. And again, the criteria will be slightly different for these, and I'll go over that in a minute. And then your final comp must be done in one sitting, one attempt, one letter grade is worth 10 points. And this is a one and done. So once you sit and do this, you need to get everything around you. This is one that's quite extensive, but it's really the mothership, and you want to be prepared for that because it will be a one and done. And midterm competencies, I spoke about those. Passing score on those, I told you, was 75% to continue to your final, right? If you don't pass the midterm, you can't go on to final. And then for the final, it's the same passing score. It's a 75% for you to be successful with one of those second 4 competencies. Okay. Follow the due dates. Late assignments, excluding those verified, will not be accepted. So just know that up front. There is nothing in terms of late, so manage your time. And then here's the big point breakdown for everything. So those 10 shadow health ones, 3 points each will get you your 30. Your 2 focus exams are 10. Your comp is 10. And then your actual physical exams with me are the other half of your grade. These weigh pretty heavy as well. And these are your 2 dates that we talked about for this class. Okay, any questions so far? Okay. And down below the part I like to show you, here's the calendar for each week. It starts with our introduction board. So some of you missed that. Some of you missed that one already. So just be aware that if you missed that one, you're already behind on assignments. Second assignment will be your DCE and your conversation concept lab. So those are this next thing due. So please make sure you catch up. You still have time. We're still early in the semester. And all the rest of the dates are there for you. And then finally, down here on the scores, the actual scores, as I told you, DCE for the regular modules are either 3 points or 0, 3 or 0. On the focused exams, it's a little different. You can, instead of 85 is greater, is broken into several categories. So for full points, your DCE score is part of it, right? If you get greater than 85, you get your full 2 points there. If you get 70 to 84.9, it's a point, and below 70, get you an unsatisfactory 0 point. But here's where I look more specifically into your documentation, how to give you points for that. There's a point attached for that. There's a point attached for your objective documentation around your focused exam, because by now you should be very good at talking to Tina, working it out, knowing how to get those subjective and objective scores up high. I always suggest you get them as high as you can. I suggest 85% on everything. puts you in a good place. 85% competency on subjective and objective and documentation, communication, all of that will show you, as I showed you on the behind the scenes of Shadow Health. And then how's your communication overall, right? Comprehensive introduction with exams, questions worded in a non-judgmental way. You're empathetic, you provide education. There's that, there's your bonus points, and appropriate closing of your exam. And that will get you full points on the focused exam. For the comp exam, similar to the other one, it's 85% up or 70, and even 70 here gets you a couple of points for DCE score. But again, I'm looking at your subjective, your objective, and your communication to build the rest of those points for that letter grade. So those things become important, which is why I showed you the behind the scenes of Shadow Health. So you can see what I see, and you can get that feedback as well and see how you're doing, and you're charting your progress on the little 3 pointers in between, right? And then at the end of this is the standard matrix, which talks about the core competencies and why you're taking this course. It's part of the BSN requirements that you learn how to do health assessment stuff. Any questions on the syllabus? Any questions on the syllabus? Okay. So I feel good about Canvas. Okay, so that takes us now to our first, what do I want to call this? First competency, which is skin, hair, and nails. And it shows you this picture. What was that picture? Anybody? Go back.
Nail clubbing?
Clubbing, thank you. That's the word I was looking for. Horrible clubbing, right? Isn't that horrible if nails look like that? Okay. So let me close the sections. I close them once I'm done with them. We talked about that. And that. I told you to look at that, and we're here. So your competency for skin, hair, nails, you should ideally have in front of you right now to be making notes on, because this will be the mothership. These competencies are the mothership. This tells you what you need to do to successfully pass each competency. So you need to really get familiar with these sheets, because these are the sheets that I pull at random when you come in to sign off with me. They all look generally the same, no matter what they are, what they are. They all start with for 2.5 points. It starts with your professionalism and bedside manner I'm evaluating. So for each of these, it says worth a half a point. So when you go in and you start any of these competencies, you always start them the same. Hi, my name is Austin. I'm going to be your nurse today. I'm going to close the curtain to provide privacy to my patient. I'm going to do my hand hygiene, and I'm going to ask my patient, what brings you in today? What brings you in today? You or your partner should say, I'm just here for a physical exam. That's good enough to say. And then you go ahead and start with the exam. When you're done with the exam, you say something to the effect of letting the person know, this concludes our exam. Thank you very much. I'll go report my findings to the provider. Okay, there's your 2.5 points for that section. That is on every single competency, right? Introduce ourselves, hand hygiene, ensure privacy, and reason for visit. Okay. Now, for the rest of the skills, skin, hair, scalp, and hair, and nails. This is a pretty easy competency. I give you this order that you must maintain consistently throughout our time together, or you will fail. Or you will fail. So hear me loud and clear. Write this down. The first thing you should do, and this is a standard on all 8 of these, there's a system I use. You inspect first. You know, before you lay hands on a patient or touch them, put a stethoscope on them, anything. We start with inspection. What is it you see? Your eyes are your first assessment tool. And you will begin to hone that in our time together as I move you through this course. What do you see? Tell me what you see, because I'm looking at it as well with you. So you must articulate your observations to me. And again, if you can articulate them, then you should be able to write it that way. So tell me what you see, inspection. Second skill, auscultation. Then I go ahead and place my stethoscope and auscultate things that need to be auscultated with my stethoscope, which I need to pull. 3 is percussion. Let me put it in the camera this way. Percuss on whatever body part, percuss. 4th skill is palpate. Always palpate last. Always palpate last. If you go in and touch first, you fail. You fail. Done. Stop clock, done, fail. We're done. Why is that? I'll ask it as a question.
Because it will let you won't be able to hear the rest of the things you're doing. It's gonna like mess it up.
Okay.
When you palpate first.
You're messing up what?
Like the sound you're supposed to hear.
Well, you don't know if you're going to be hurting the patient because you don't know what's wrong with the patient yet.
Okay, I like both of those answers. Great. I like where your thinking is. What else?
Well, the demeanor of the patient is going to change. Like when you start touching the patient, they might move certain ways. They might start looking uncomfortable. So you have to look at them first to see how they look. If they're comfortable with, like their body language. So with the body language, when you first look at it, it's going to change after you touch the person because.
Right. Yes.
Okay.
Good. I like what you're saying. Beautiful. What else? Anything else?
I don't know if this is related, but for the GI, I know we do palpating last because sometimes when we palpate before auscultating, it can like affect the bell sounds.
Exactly. Ding a ding, 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 ding. Okay, all of those are beautiful responses. So it's like when I walk into a room with a patient in a bed, I don't just go in there and just grab and pull the curtain, pull the blankets back and start putting my hands on them, right? We don't do that. That's not how you operate. You start with what do I see? You should be picking up information from people immediately upon seeing them and laying eyes on them, right? I should already start registering stuff, right? And I can be asking them questions about what I'm seeing, kind of like we just did with the toe role play, right? I'm already seeing stuff that may draw suspicion or have me ask questions or make me think old cart or make me think Caldera, right? That I see some stuff that draws question. That's where my assessment will start. So as we're looking at this particular first assessment, which is always a little tricky, this one, you have to, in my mind, and you create your own order of how you do this, what you do on these different assessments, but you always start with inspection first. So how you do the rest of that, I don't micromanage. Each of you will have a different routine that you feel comfortable with or a different order that you feel comfortable with. And that's fine. Actually, I'll go down to the bottom of the form because you're being graded on your organization, your flow. You're also being graded on how well you do the techniques that we're going to be talking about and teaching you, right? That's there's 3 points right there. Remember, you need 75% of this 25 points to successfully pass.
Professor, where's the files located? Just in the, because I was looking in.
That's okay.
Connect, okay.
That's okay, I'll go back. Great, ask me your questions, that's what I'm here for. I love questions. So they're under right here, under these competencies
Oh,
are
okay, 'cause I went there and I didn't see it. Okay, I'll try it again.
midterm competency rubrics. She put them all together here.
Oh, my bad. Okay, thank you.
That's okay. Just ask me your questions. That's what I'm here for. I don't mind.
Dr. Nation,
Yes.
were you gonna give us like a scenario? Because obviously if we're doing it with our partner is not gonna come in with any lesions or anything that we can inspect. Are you gonna give like a
Oh.
scenario, or are you gonna be like, okay, well, this person, your patient's coming in for this?
Oh, no, you don't need scenarios because you have 10 minutes. I am looking, this is a skills lab. You don't need a scenario because you're not doing a whole bunch of verbal communication. So you don't need a scenario base for these. Because for these competencies, it's just the skill. Now you're jumping ahead a bit and I will go there. So for example, on this first assessment, you're gonna be looking, inspecting, looking. It says identify and describe one lesion. That's an inspection skill, right? Everybody has a lesion, a bump, a bruise, or something, something, something on them. We all got one. If you don't have one, we'll pretend you got one. But I always find a little scar. Okay, let me get to the camera. Okay, there it is. There it is. There it is. That one right. I'll use that one right there. See it? So, description, size, location, tenderness, warmth, drainage, exudate. I'll start here with this one. Let me get it. Where's my camera lens at? There it is there. Okay, I'm gonna hold it for a little while. What's your assessment? How would you give an assessment of this lesion, scar, whatever it is? You just find something that you want to identify. So I always start with myself. I won't put you on the spot.
Is it open to anybody or who's answering?
No, this is open. So let's start with, you want to do them in that, you can do them in this, but let me do with I'll prompt you. What's the location?
Near the antecubital.
That's a vague description. That's an associate degree description, near the antecubital. Antecubital is over here, antecubital.
Oh, my bad, sorry, cubital.
Okay, so let's be specific.
Near the elbow.
Our location. Let me go back. Let me come back on camera.
Close to the elbow.
Close to the elbow. That can be anything around here. You want to be more specific. Again, I'm going to hone you in.
At patient's left internal elbow.
Oh, you're getting closer. Love where you're going. Internal elbow. Okay. Lateral elbow. There you go. Lateral versus medial. Is this lateral or medial?
Medial.
Huh?
Isn't it towards the body? Isn't that medial?
Toward the bottom is toward the body. Is
Body.
medial. Yes, I always think medial near the middle. It's near the middle. Okay, now you're getting more specific. Okay, now keep going. Location. Anything else?
Is that part of the upper portion of your forearm? I can't really.
Okay, there's my whole arm. I have a long arm because I'm tall. I'm 6 foot something. So right about there, medial aspect of, okay, of forearm. Okay, oh, my arm's getting tired. Okay, size, or how would you describe it? I'll take either one of those. Size or description. All right.
Roughly a quarter, or I can't, maybe it's
Right.
Well, you can compare it to my fingernail size. So my fingernail is not a quarter size. I tell you, my
okay.
I
So
think
like
it's that big.
a centimeter and a half or something.
Centimeter and a half, you could say. Okay, or
Half a meter.
half what? What'd you say? Give it to me again, Jennifer.
About half a meter.
Half a meter. Okay.
It's like irregular shaped.
Irregular shaped, pea size, quarter size, golf ball size, right? Watermelon size if it's a tumor, right? I mean, or cantaloupe size. You can do some common kinds of visuals if you want to give them that. My arm gets tired. Okay, irregularly shaped. Let me come back to the camera. What else for that? Size. Tenderness. How do we know tenderness?
We ask.
You have to
Ask.
ask the patient, or
You feel it.
Oh, you feel it.
you can feel. But remember, we're saying always start with inspection.
Inspection.
Or I go put my hands on it. I'll be putting my hands on it, right? I would ask the patient, is there any tenderness in that area? And in this case, I would say, no, this is an old scar. Now, warmth, you have to touch, palpate skill. Drainage, exudate, any?
No, it's
No.
dry.
No. And I would also tell you, once you did palpate, when we get there, you'll be laying hands on to feel for what?
Roughness.
Roughness, smoothness, texture, right? Good. You get where we're going. Make sense? Okay. So let's back up. So that was me answering that question. So inspection skill, we start at the top. I'm looking, inspect, palpate, assess. This says assess Tuger. Which category does that fall under?
Skin, or what do you mean category as far as?
Assess Tuger tenting. Where does that fall under the major 4? Inspect, auscultate, percuss, palpate. Those are your skills. So you've got 4 skills you're learning. So every competency, it's a palpate skill.
It's palpate, which you're touching the patient.
I gotta lay hands on, right? Exactly. All right, identify and describe. This one is combination, inspection, and because tenderness and tenderness and warmth require you to do what?
To
touch.
feel.
Right?
Touch.
You're tracking? Okay.
Do you want us to go through each one of these categories with the visual and verbalizing what we see?
Oh gosh, yes.
What?
Oh yes.
Okay, so no, but like do it all in one foul swoop, every single section, all visual, all explanation, and then come back and do each section touching? Or do we mix and match?
Great question.
Because
that's where I don't micromanage it. Remember I said I don't micromanage.
Okay. Yeah.
I'm going to teach it to you the way I just suggested you get in the habit of doing.
Okay.
These rubrics are just there to be rubrics. When you
Just as long as you don't touch first.
you get right. There you go. Well, don't you be laying hands on first.
Okay.
Like done. Clock, stop, clock out of the room.
All right.
Right.
So when you're saying don't touch first, you just mean start introduction, build rapport,
Start with assessment.
questions, state your visualizations, and as then you progress through, there's going to be portions in time when you're allowed to touch the patient.
Of course.
Okay.
Remember, in this 10-minute window, while you're practicing your routine for this one, you will put together the order you want to do it. Some of you may be very linear. You may want to go, oh, I want to do skin first. So I'll do my skin in my brain. Your brains are all different. What I say, there's 18 of you. You all think differently. I may say, okay, he said, don't touch first. You're clear on that one. So maybe for skin, I go, okay, let me run them all first. Inspect, auscultate, percuss, palpate. That's what he said to do, right? Blah, blah, blah. So I'm just going to start and just do skin first. Let me do all my orders of that skin first. And then I'll move down to my scalp, hair, and nails first. Inspect, and here's another palpate, right? And actually, this one's a combination, inspect and palpate for hair. And then these are inspect and palpate as well. So to your question, Andre, if I were you, I might say, I'm gonna knock out all my inspection stuff first. Get in the habit of that, because that'll help you with ones down the line. What do I see first? What do I see? Just pause, stop. Look at this patient, skin, hair, nails, skin, hair, nails, skin, hair, nails, skin, hair, nails. What do I see? Skin, what do I see with skin? Let's start with skin. Inspection of color, cleanliness, vascularity, and lesions, it says. I'm looking at this person's skin, or I'm looking, you can use my skin. I'll pick on me first, but you'll get with your partners later and practice it. What do I see in terms of color? How would I describe color? What are some words for color, for a person of color?
Normal to ethnicity.
Normal to ethnicity. I don't like normal. Normal, get rid of that word. Because we get normal. What does that tell me? Nothing. It tells me nothing. So I might choose to use something more descriptive, appropriate for ethnicity. I like that wording a little bit better. Okay, because I don't want, I hate students to use normal. Don't tell me normal. Don't write normal. Get out of the use of normal. Normal tells me nothing. It's normal. Appropriate for this person's ethnicity, who's African American or who's Asian Pacific Islander. People of color. Be more descriptive. Okay, don't use normal. Normal will get us in trouble down the line. Okay, what else? What other colors of the rainbow are there for folks?
Pale, you could use pale, pink, mottled.
Our liver patient earlier taking all my Tylenol.
Jaundice.
Jaundice, thank you.
Yes.
Got it. Patients may have issues with their skin on observations. Things like vitiligo. Ever seen, I just saw one of my coworkers has that. Ever seen those before? What does that look like?
Is that the white spot one, or is that?
It's the white spot. It's the white spot one.
Yeah, it usually starts in the hands, right? Like the fingers.
Yeah,
they
he has,
become
I see it here and I see it on his hands, right? Mostly on his face. There are some great pictures of skin illnesses and problems in your book. You can avail yourselves of some of those wonderful graphic pictures that they have in the book. They cover a lot of the skin stuff there that you can see. Some great pictures. Where's my book at here? Where did I put it? Anyway, there are some great pictures here. I'm not finding the book here handy. Okay, but there's some great pictures in your textbook. I don't know, where's my book at? I just had my book here. Anyway, I'll come back to it. But some wonderful pictures in there. Things like erythema. What does that look like?
Redness.
Redness, right? Areas of redness, right? So I would notice anything around color. Cleanliness is pretty straightforward. Does the skin look clean? Does the skin look dirty, right? Vascularity, you may see issues of hypervascularity, particularly on people, alcoholics, they get this thing around the nose where there's areas of hypervascularity. Lesions, such as scars, scrapes, distinguishing marks, I would call these on inspections, right? Any kind of lesions, tattoos, descubitus. What do I see with this person's skin in terms of things that could be considered sort of out of the ordinary, normal versus abnormal? That's what we're trying to differentiate. Everybody's skin doesn't have these things on them, piercings, right? Those kinds of things I would take note of. Anything that's everybody doesn't have. Okay, inspection. I moved down to inspecting, then we did our lesion, because we said these are all palpate. I'll come back to palpate, but I'm just gonna keep inspecting first. Then I'm gonna inspect the scalp. I'll just look at it. I used to have hair, so now your inspection of my scalp, not touching it, but just looking at it. What do you see on this person's scalp? Lesions, it says scaling, it says infestations. Do I notice any of that? Maybe there's some dry, flaky dandruff stuff that's happening in there, just looking at the scalp and that, right? And inspecting the scalp and the hair. What do I see of areas that are exposed of their scalp, right? Or around the edge of the scalp, what I would see, right? In terms of scaliness, dryness, flakiness, right? God forbid I see things crawling in on their scalp or hair, but I could, right? I wouldn't put myself beyond that. And I would take note of those upon inspection. Color of the hair, I could notice with my eyes, my assessment tool. What am I seeing? Do they have hair? What color is it? Texture requires me to touch. Distribution is an observation. I would notice if they have a full set of hair, if there's thinning of the hair or alopecia, right? If there is male pattern baldness happening, if there are patches of hair that are missing, I would take note of any kind of issues around symmetrical distribution. Does the left side look similar to the right side? That's what we're looking at and comparing to. And then inspection of the nail beds, color, hygiene, angle of attachment. So for nails, let me go in close to nails. You're looking at someone's nails. Are the color of the nails, they should be pink. Ideally, there should be some pinkness to them. When I look at the angle of attachment, which is kind of hard for me to show on this, though. Okay, there is one. I can get that one there on screen because I just whacked them all off. Angle of attachment, there should be, there it is right there. That's a good angle. There should be some curving to the angle of the attachment of the nail so that the nail is not flat, it's not, or it could be concave, or it could be, it should be a nice little roundness to it just upon inspection, and the nails should be clean. Or they should not be dirty. So I can notice these kinds of things about the nail and the health of the nail just by inspection of it. And that would be all the inspection skills that you're being asked to do for this particular, oh, cyanotic for color. I got to keep an eye on chat. You guys are chatting. Thank you, Nicolette, for your chats. Appropriate for ethnicity. Yes, okay, I'm just noticing chat. So I'm going to keep my chat box open. So I've done all my inspection skills. Auscultate, second one, there is nothing to auscultate with skin, hair, nails, right? We're not percussing, third one. And then finally, the fourth one is palpate last. I'll keep reinforcing that one. So now I can start to lay hands on this person. Okay, I palpate color, I'm sorry, temperature, moisture, texture, consistency of the skin. I would pick an area of the skin to lay hands on to see what the skin feels like. Temperature, I usually glean with the back of the hand. I think this is a wonderful assessment tool to check temperature. You have this part of the hand. Well, these two fingers, you know for what? Radial pulses, right? These are our tools for those. Palpation, you use all four of these as your instrument for palpation, right? It's all the, when I'm doing a palpation, I'm palpating with all of you. I'm not doing a palpation with two fingers, right? Let me go on the screen. Two fingers this way. When I palpate, I'm palpating with sort of this part, it will be registering the information up to my brain. But for the sake of this part of the assessment, we're just palpating for moisture, temperature, texture, consistency. The skin is smooth, it's soft, it's scaly, it's dry. The texture is soft. That's the consistency of it. There's, I think I gave you most of the words in there that you could come up with for that part of the palpation of the skin. Moist, dry, sweaty, sticky, descriptive words of what you're feeling on the skin. Palpate for edema times 4 extremities. Edema, we all know edema happens in the hands and it happens in the dependent areas of the feet. Same thing with edema, you're palpating it. It's the old push test, right? So I want to push, no edema, no edema, no edema in the dependent area.
There's no pitting.
If I put my finger all the way in there, it would be like, oh, that's pitting edema. And for pitting edema, if I pushed in, oh, it goes in, it stays in. Then I can say it's 4+, 2+, 3+, and there's a scale that you can use to identify the degree of edema that happens in both the hands and the feet. I told you that this assessment for skin tugger really falls under palpation. The only way to check for skin tugger is to take the skin, pinch it up, and bah, it goes. Huh?
I said when you pinch and let go.
Pinch and let go, correct. And so in this case, when it rebounds back like it does nicely, bam, it goes back into place. What do I say? No problems with skin tugger. There's no tenting, right? If I pinch and I let go and it stays up, what does that tell me?
Dehydration.
Dehydration.
Hydration.
Hydration. We're thinking probably dehydration could be just an old person. Old people have issues with their skin around,
Right.
right? Just being elderly. It may be appropriate. If I saw a 30-year-old with tenting, that would be an abnormal finding. I wouldn't expect to have a young person doing tenting on me versus an 85-year-old, right? So I'd be noticing the skin tugger, good skin tugger, skin rebounds upon pinching for tenting. I could be even more descriptive, right? And then we did our lesion already. Then we can move down to palpating into the hair. Now I'm gonna go into the hair. And I've inspected it earlier. Now I'm gonna go in and start palpating the hair and seeing what I see. And I feel, oh, this hair is soft. The texture, the consistency of it is nice and soft. It's coarse, it's dry, it's brittle. I can come up with some words for that to describe what I'm feeling on this person's hair. And then the same, while I'm here, I can also palpate skull. I want symmetry. Maybe, oh my gosh, this side's really firm, but this side has a soft spot right there. I wonder what's going on there, right? It's a soft spot. It again should be symmetrical left to right. Are there any other kinds of deformities when I palpate the skull, right? Tenderness. I might ask my patient, are there any areas here that are tender when I'm touching your scalp, right? And I would take note of that. Or if they grimace, I hit here and they go, oh, ow. That's a sign that something's wrong. That's a red flag. Okay, so I'm taking note of those kinds of things in my assessment. And then finally, we come down to palpating these nebus for firmness, ridging. We're doing these on upper and lower extremities and capillary refill. So are the nails, when we go into the nails, is there a firmness to the nails? Is there any ridging of the nails when I feel, am I feeling this little thing, this little area of ridgeness? Are the nails smooth? And then cap refill, bada bing, I push down, I let go. What do I expect for cap refill?
To return.
The blood flow to return.
Yeah, but what is it? What's the measurement I'm looking for? What's the timing?
Less than 3 seconds.
0.3.
Less than 3 seconds is your what?
0.3.
Normal.
Normal.
Okay? I don't like that. Remember I told you I don't like that answer. What I like is an accurate assessment of your capillary refill. So as I'm standing over your shoulder, watching you do it, and you push that nail and let it go, and you get immediate capillary return, it's 1 second, then you tell me it's 1 second. That's an accurate assessment. Don't just say under 3 seconds. That's just the range. That means nothing to me. If I push that nail down, 1001, 1002, 1003, 1004, 1005, it took 5 seconds for it to come back. Now what's going on?
You have slow perfusion due to some reason?
Slow perfusion due to some reason. Let's go upstream. What might be some of those reasons?
Oxygen.
Dehydrated.
Dehydration, oxygen, perhaps oxygen, but more commonly issues with perfusion have to do with what? Because I'm always comparing
Blood pressure.
The patient may be
Hypertension.
her blood pressure. I heard Wells.
anemic, maybe anemias, if they're low, like anemia, or if they have some kind of like CHF or some kind of other oxygenation problems.
Oxygenation, pulmonary issues might cause delays. Yes, what else? There's a more common one.
Could be.
I do 5 seconds on the left and 1 second on the right.
What about like peripheral artery disease? Could that cause it?
Yeah, that's clonus.
What are you thinking?
Neuropathy.
Perhaps neuropathy, but more common. What do we, capillary, we're testing what?
Clotting?
What is it?
Like diabetes, peripheral artery disease, stuff like that.
Tuberculosis and clotting on the left hand.
Here's what I was going for. Thank you, Andre. Vascular system, right? I'd be curious, are they perfusing down to their extremities? And if there's a difference between the left and the right, I'm going upstream. Is the blood flowing all the way down to that extremity the same way? And I begin to think vascular, is there some kind of occlusion? So
it could also be cold too, and they could
Yeah,
have,
that's what I was gonna say too.
yeah,
And like you can
Nurse.
tell like the skin color would look different too if the peripheral, if they were getting perfusion on one
Okay,
side or the other,
rewind.
you can compare the other two.
I would concur with you with that, and I'll go temperature next. However, my assessment findings was 1 second versus 5 seconds. So if this was a temperature thing, let's walk through it.
I was going off of like one of the other things is that if it's cold and they have arthritis in a particular hand, you can get microvessel occlusion to some degree if they just need to warm up their hand, and it goes from 5 back to, let's say, 2 or 3.
Okay, I like your rationale for that one. Yes.
Yeah, it could be an inflammation issue too.
I would take that, yes.
Yeah.
But typically, in my mind, if this is going to be a temperature thing, would it not affect both extremities the same?
Yeah.
It
will. Yeah.
Right? If it's a temperature thing, or if it's an oxygenation thing, right? Generally speaking, what I see on the left side of the body, the heart is only one heart pumping out to this system. It should be similar left to right, left to right. We constantly are comparing left to right, left to right, left to right. So if it's affecting this individual, it's temperature-wise, it should affect them vascular-wise if they're having issues with vasoconstriction. Me, I have cold hands. Both of my hands are cold. It's not one hand's cold, one hand's warm, right? So I begin to go upstream and say, vascular, are there a clot, occlusion, arthritis, surgery? Maybe you find out later once you get more information. Maybe I had a wound or something that was cut on this side or this shoulder. They did surgery on, which they did, on my left side, on my left shoulder. That could impact my peripheral vascularization. Does that make sense?
Or some medical history like Raynaud's disease or something like that.
Or it could be some other disease process. I would go along with that as well. Yes, absolutely. I like where you're thinking. I love y'all's thinking this morning. Y'all doing great thinking, but you get where the critical thinking behind it. So what are these assessment findings telling me? That's kind of where we're going, right? Much like the difference between vascularity, it says bilateral BUE, bilateral upper extremities, bilateral lower extremity. I can go down to the feet, and again, I'm not putting my feet on camera, but if you go to your feet, you do your capillary refills on your toes, I would expect the same kind of similarity between the left and the right on the feet as well. Okay? It's the same kind of thing that you're assessing on the person's toes. All right? And that has gotten us through our first assessment. Any questions? Any other questions? That's good thinking. I like that.
I want to ask for the size of anything we might be using. Must it be like exact size when we want to talk about size in the assessment?
Size of what?
Like when you showed us your little thing by your elbow. Yeah. Must we be exact with the size when we're talking about sizing it? It has to be exact size.
Generally speaking, because you don't have tools. I think with Tina, Shadow Health gives you some tools in there. I know students do them because they tell me that it's in there. I haven't played with Shadow Health in many years. But tools, they give you tools so you can measure. If we were in class, I would give you, let me see if I can put my hand on it real quick. I would give you little, and I may put these out during our time together. Oh gosh, let's see.
Paper rulers?
Yeah, well, they're actually really, no, they're these. I'm gonna show you, I'll show you on camera. They're, oh, I need to show it against a white background. Oh, here.
Can you stop sharing your screen so I can see, so we can see like a bigger picture? Sorry.
Okay, thank you.
Okay.
Okay, you want me to do, can I do a spotlight of my view? Hold on. Spotlight for everyone, me. Okay, there we go. Okay, so let me bring it up. There it goes. So you can see it has your 1 centimeter. Uh-oh, where's my finger? You see it?
Yeah.
So in the middle is, what can't see my finger on there now.
That-
Oh, because my camera's up here, duh.
Let's see.
Look,
Where's the finger at?
if you flip it around, it'll be left to right.
Yes. Yeah, I know, huh? I know. And then also on this beautiful little instrument, it has a little ruler on the ends. So I know why it is backwards. Are you seeing it backwards?
No, we're seeing it. I'm seeing it. I don't know for others.
Are y'all seeing it backwards or forwards?
No, it's fine. It
It's
was
fine.
just-
It's fine. It's just the way the camera is.
And then at the bottom, it's in metric, right? So you have inches up top. So if you like inches scale, it's 1 inch, 2 inch, 1/4 inch.
I
or
have one of these at work, but it's more looks like a ruler. Do you mind if I like get one from my job? And
You don't
I
need
can
them.
scan
Don't
it in?
buy anything.
No,
Don't
for
buy
this class to show them. Like I can scan them in. I can scan them in and send them to you so that you can upload them and other people can see other like wound care.
Oh, sure. If you want me to share something.
Wound care. Yeah. Yeah. Okay.
Yeah.
Everybody has like an idea because that one's I've never seen that one before. I only have the
Well,
one
you
I see at
did-
my job.
Will you be using that one for the actual
I'll
assessment?
have it available for the actual competency. I'll pull it off. But usually what you all do, because you will have practiced with your partner plenty before, you will have picked out this lesion in advance. You will have prepared what you're going to say to me about this lesion. You would have done all your assessment of the lesion. You're pointing it out and I'm just confirming it, right? So it's like, okay, this is the lesion we're talking about, Dr. Nation. It's about pea-sized lesion on the medial elbow, right on the right, maybe. I could even get more specific and say it's so many inches from the elbow, the actual end of the elbow. If I wanted to get, say, 2 inches from the right, the junction of the elbow, I could get really specific, right? I can get really descriptive of what this is. That's what you would have prepared in advance of coming in to see me.
Oh, I thought you were picking it out on the day.
No, you are no. I'm not gonna, I wouldn't derail you. That wouldn't be fair. I want you to come in rehearsed and practice with your partner.
Okay.
That you two have already talked, you found that little lesion. I'm picking on me first because I'm being gentle with you all before I start picking on you today. But start with finding a lesion. Your partner can usually tell you one. Maybe people, if they don't have one, will have to pretend there's one. So you may have to tell me, okay, my partner has no lesions. My partner has not one little lesion, blemish,
Just draw a little lesion.
pimple, something that I can talk
A
about.
pimple.
I don't know. Nice. I don't know. Talk about
That could be so insecure. Be like, whoa.
You got to give me something. You know what I mean? We got to talk about something. That part alone.
What about a quarter-sized zit right on her forehead?
Right here. This is right there. Talk about it. You know, that's how I'm gonna pick on. I'm not picking
Looks
on you.
nasty. Looks like she picked at it because there's a scab on it. I don't know.
It's gonna be descriptive.
So definition,
Yeah.
we have to get it from our partner, correct?
Yes, just that's why I'm starting with me first. I'm being gentle. I'm not usually, I used to start this course by saying, okay, show me where your scar is, but I don't. Now, if you have a scar that you're willing to share with the colleagues, anybody have a good scar you want to share on camera? You can share.
Right here.
Oh, you got one? Okay,
I
carry it.
don't know how to move my hand. Hold on one
Hold
second.
on,
Let me
let's
share my
spotlight-
screen.
Let's spotlight you. Let's see it. Okay, what you got? Show them what you got.
Hold on one second.
Mm.
Okay. I have this.
Oh, that's a good one. Everybody see it?
Mm-hmm.
You want to describe it?
So it's like a bet mag.
No, you don't tell them. You don't tell them. Let them.
Oh, I'm sorry.
You already know. You've been living with it. You know what it is. Turn it so they can see it. Good. Oh, I like that one. Students. That's a nice size one too. Students. What's your assessment?
I don't know, 5 centimeter right lower, right arm, lower forearm, medial, discoloration, darker than patients.
Good.
That's
Non-tender,
Um,
non-tender, no drainage.
no
Yeah.
drainage. Does it look smooth? I can see it kind of, it doesn't look, it looks smooth.
We don't
It
know.
looks
if it's
smooth, but you have hairs.
It
kind of
doesn't
rough.
hair. We can't see. Okay, we can't see that great detail. Okay, you have to. I can't see that detail.
yeah.
That was good. See what? That was good. You guys actually ran that one. That was nice. You get my drift. Thank you. Thank you for sharing your Carrier.
You're welcome. No.
That was a good one. Okay, so you get the drift.
Yeah.
Skin, hair, nails. Skin, hair, nails. Okay. Any questions? Is the partner we are assessing for the midterm competence scale anyone we choose? No, it's the partner we just assigned. That's your partner for the course. Yeah, no, I'm glad you asked that question. No, it's the partner you all have matching partners. I've matched you up. So let's do a little bit of time. I'm going to put you back with your partners right now. And I'm going to give you, let's do 15 minutes of talking with our partners about skin, hair, nails. Okay. I'll give you each about 7 minutes just to start, because this is just to start talking with your partner about it. Just start talking with your partner about it. Skin, hair, nails. Let me make sure I got your breakout room still. Yes. 15 minutes for this one. And I'm going to be passing through the rooms. I'll be coming around. Any questions? Okay, here you go. Here with your partner. Okay. Now, you going in, Julia?
How do I go in?
You should have gotten an invite on, let me see, where are you at? Unassigned. Why are you unassigned? Oh, did your partner leave? Oh,
No, you know what happened?
okay. Okay, welcome back. Okay, I'm gonna pause. Actually, I'm gonna stop.